Is my voice audible here?
Yes, sir. It's
Yes,
audible.
sir. Yes, sir.
Yes, is it fine? And it's sound?
Yes, sir.
Yeah, okay. So today's session is about a very, very important landmark in physiotherapy field. It's about the STEP conferences. I hope some of you who are seniors would have definitely heard about it. It's a conference which happens once in say 10 years or 15 years or 20 years, depending on whenever the field of neurosciences sees any new invention or new discoveries come in and it is time to change the field, then we do have when it's time to change, we do have this conference being conducted. So it's a very special conference. It's unlike the other normal conferences, which happens once in a year, once every year or so. Now, we have had since the beginning of the times, we have had a folk conferences. They are called as New Step, First Step, Second Step, and Third Step. New Step, Second Step, Third Step, and Fourth Step conferences. What is very interesting about this conference is the field of neurosciences has grown, and anyone who listens to this conference can understand how much we have traveled in neurophysiotherapy from the earlier periods. So today, what we'll be doing is I'll be starting with the first one, which is New Step conference, what happened in the New Step conference. Then it will be followed by the other speakers. Dr. Vipinath will be talking about the Second Step conference. Selva sir will be talking about the Third Step conference, and Sheikh Abdul Qadir sir will be talking about the Fourth Step conference. Okay. So I'll just try to. Is my screen clearly visible?
Yes, sir.
Yes, sir.
Yes, Vasantan.
Yes, sir. So I'll start with this. The story started in 1966, approximately 55 years back, in a place called as Northwestern University. This is its old picture of the campus. And this conference was called as a Special Therapeutic Exercise Project. And the conference per se was a 4-week conference, unlike the current conferences, which is 1 day or 2 days. And there were around 20 days of deliberation. And the conference was planned for a period of 2 years. They had planned. So before going to the conference, we need to understand that period of physiotherapy, how it was happening. What I'm talking about is predominantly about US, because the STEP conferences are generated there and it has been continuing there, although there are participants from all over the world who come to the conference. So we would first take a look at briefly about the curriculum which was there in the 1960s. Okay, right? Now you can see this page, which is course in physical therapy and occupational therapy in 1960s, which was conducted by Columbia University. Now you can see there There were two types of PT programs predominantly over there. One was a certificate program, which was 1 year duration. And this was the syllabus of the certificate program. Okay. And we had a degree program, which was basically a 2-year program. And this was the 2-year program. So you had a junior year and a senior year. The junior year was around 6 months, and the first, it was divided into 2 terms, the first 6 months and the second 6 months, and you can see the various subjects in this. Okay, right? So in the second year, if you see the spring term, we have clinical application, clinical experience, electrotherapy, kinesiology, and then neurology over here. Right, that's clinical neurology, and then you have physical therapy and rehabilitation. Okay. Now, when we go into the syllabus per se, what was the content of it? Here you can see the junior year term, first term, and junior year second term. What was the syllabus in here? We don't see much about neurophysiotherapy in this particular part. And again, this also is the first and second year. Now, second year is the senior year. You can see here, supervised clinical practice, general medicine and surgery. And then you have neuroanatomy. And that's about the first term of the second year. And then in the final term, you have the following paper, clinical neurology, as we said, and physical therapy and rehabilitation. So the rehabilitation and physical therapy, you can see here, are very, very, very small units. So it's just 6 months, and within that 6 months, they are going to cover, say, 6 or 7 subjects. So hardly 1 month was the course. This was the content of it. Now, at that time, what was the exercise which were provided? Now, first one is the historical nature of the exercise. Traditionally, everyone were doing exercise, which was general exercises. And then the medical people who came in, they started calling the exercises as medical exercises or corrective exercises or therapeutic exercises. That's the difference between what we normally do in school and what we do for a patient. That's how it was called as. Okay. And these medical exercises predominantly had active movements, resisted movements, primarily strengthening exercises were there. The other treatments were passive movements, stretching, massage, electrotherapy, splints. The only special exercise which we still use today was the Frenkel's exercise, because it was found in 1850s and it was there in that time. We all know that we had Bobak approach and Brunstrom approach, which started in 1940s. But we need to understand that at that point of time, they were all practiced in specific clinics and some areas, but it did not reach the mainstream medical curriculum. Okay, right? Now, this is an excerpt from a book on physical therapy, and the whole content of what physical therapy was there is just summarized in these pages. Okay, right? So this is the first slide, and this is the second slide, and they predominantly tell that in the subacute stage, physical treatment may be instituted in 2 directions. One is for accelerating the circulation in the brain. They had cerebral galvanism, transcerebral calcium, iontophoresis, and even cerebral diathermy. Okay, right? So these kind of treatments were tried upon during those times. And electrotherapy had a major role during that period, and it was used for stroke patients. When it comes to exercises, it was a few set of exercises which we have seen before. That is what were given. So against this backdrop, we have a conference which was planned, and it was an exploratory and analytical survey of therapeutic exercises. Now, at that point of time, what people felt was there are many newer forms of exercise therapy which has come and which was developed based on a deep understanding of neurophysiology. So they all thought that it's time that we reevaluate the exercise therapy in light of this new information. So a conference was planned wherein it did not have only physiotherapists, it had educators, researchers, clinicians coming from different fields. And the conference, as I said before, was planned for a period of 2 years. Now, the specific objectives of the conference were, well, number one, to come to agreement on therapeutic exercises. So it was an agreement, which means the whole country wanted to come together and then plan, okay, what is the exercise that we need to give for a specific condition in a specific situation. Number two, the conference objective was to gain basic understanding about normal motor behavior and motor learning, and then to analyze the traditional new methods of treatment and elicit what are the commonalities and what are the differences between those newer approaches. And based on these understanding, to develop teaching objectives and to design courses. So the 4 weeks of the conference, that is a whole month, happened, and every week there were around 5 days which was there. So in the first week, they reviewed the historical basis, that is what all were happening in the present practice in clinical use of exercise therapy. Then on day 2 and 3, they were discussing about what was the normal motor behavior. That's how does a normal movement happen and what are the mechanisms that underlie these normal movements. And then on, we have the characteristics of mature motor behavior and what is deficient in patients. So this was the major theme in the first week of the conference. So in a normal motor behavior, they had 2 parts. One is about the development of normal motor behavior and the other one is motor behavior per se. So for example, this particular session on development on motor behavior, they discussed early reflexes which were elicited by cutaneous stimulation. What were the sequence of development of reflex activity and reflex activities of upper and lower limb, and the direction of development, that is from proximal to distal or distal to proximal, how it is developing. They had a detailed discussion about this. Now they came to a conclusion that motor behavior is purely reflexive in nature in early fetal lifetime, and it continuously keeps on expanding towards a total pattern, but still even adult behavior was reflexive. That was the major theme. So this is a small excerpt from the session. They had discussed about what are the stimulus and what are the different types of responses and at what age it starts and what age it ends. That was the discussion. The next one was mechanism underlying the normal motor behavior. So they had a very, very detailed session on the functions of different structures of the nervous system. Almost you can see here, all the systems are covered. This is a small excerpt from that presentation where they had gone and see some of the details. It is really, really bewildering to look at it at the current point of time, because at that point in 1966, they had a deep understanding about gamma fibers and then the nuclear bag and chain, and they were interpreting how they are functioning. They had also separate sessions on each one of these, from peripheral receptors to skeletal muscles. They had on proprioceptive reflexes, exteroceptive reflexes. All these were separate sessions and different speakers were there. Okay, right? There were also demonstrations of these reflexes in normal individuals. Now, at the end of the week, they were discussing about the whole movement. Initially, they discussed about the different components of it, how it is building, what are the individual structures, and then on they went on to discuss about the whole of the system and how we generally move. So under the functional concept of motor control, there are 2 systems they discussed. One is pyramidal and extrapyramidal, and one is responsible for movement, and the other one was thought to be responsible for tone. That's one of the themes that they discussed out. They also saw that reflex was a supportive framework for voluntary movement. They had sessions on normal gait and what are the characteristics and how is it controlled, characteristics of coordinated movement, and a deep discussion about the reflexes. So these are some of the pictures from those sessions. And it's very interesting to see that in this, they talked about coordinated movement. At that time, they had the EMG and they had looked into how the EMG works, how the EMG activity was happening across multiple muscles when they were trying to produce a movement, and they had recorded it and they had displayed it. There was a special paper on cybernetic foundations for rehabilitations, which talked about human interaction with the environment and general purpose of the human action. So almost all of the syllabus, whatever we are seeing now, they had a deep discussion about it. And these are some of the pictures and experimental procedures they have used in order to identify. You can see that a subject is standing on a foreleg, and there is an oscillograph which is showing the movement. Okay, right. So we do have an advanced version of this currently in NIMANS, which is called as a posturography. So you can see that. And they had conceptualized movement in quite a number amount of complexity, as the picture on the right shows. Right. Now, moving on to the second week, they had a lot of discussion on vital and related function. Basically, this was a discussion on how the ANS system, autonomic nervous system, functions and how it controls. And in the second week, they also had a discussion on motor learning. They had sessions on it. So in the motor learning sessions, predominantly they had a session on role of practice in perceptual learning. Now we know that we do have a lot of different types of practice. For example, mass practice, distributed practice, whole practice, part practice. So a lot of things. So they even at that time, these things were there, and they had a detailed session on this. What is more interesting is they had a session on motivation and how it influences learning, and a lot of other factors, how they are influencing learning. Okay, right? And you can see here some of the excerpts from that particular part of the conference. So you can see terms like response constancy, information coding, input and extrinsic feedback, and task complexity, and various other things. And you can see on the right side some of it on whole and part as practice. You can see here a graph which they have plotted on how much time people took in order to learn a particular skill, and they had noted it down. It was a curve which they noted it, right? And even these ones are very, very important for us at the current point of time. And they saw that they compared, you can see here, physical practice with no practice and mental practice, and they had drawn the lines of the improvements which have happened after multiple practice trials. Right, so this was an excerpt from motivation learning. Now, in the week 2, they also by the end of week 2 and entering into week 3, they also analyzed traditional regimes. What are the equipments that were used to support these different therapies, and analysis of methods for facilitation inhibition of motor activity. And they compared what were the traditional methods and what were the new methods. The facilitation inhibition was the new method, and the other traditional methods were the ones which I spoke in the earlier part, where I told about the strengthening exercises, the stretching exercises, and so on. So they had a lot of demonstration. Everyone came and demonstrated how they give the exercise, and then the newer treatments were also demonstrated. And at the end of week 3, they had a discussion on what was common between the new methods. Okay, right? So these were some of the traditional methods which they were using: total body relaxation, progressive resistance, posture exercises, muscle re-education, bed exercises, segmental exercises, and so on. Right? And in the newer methods, they predominantly talked about 5 different methods. They were Bobath approach, Brainstorm approach, neuromuscular reflex therapy, also called as the temple frame method, PNF, and Roots approach. These were the 5 basic approaches which was very much new and contemporary at that point of time. So people who had been practicing that, sometimes even the founders of such techniques, they were there in the conference and they had demonstrated how did they give these exercises. So you can see some of it. And I hope all of you will be very familiar with this picture on the right side with a kid in different position. That's the approach we see how in different developmental positions we need to go one after the other. Right? So the derivations where they took all the traditional exercises and compared it with this, and then they asked what is new? How does these approaches, these 5 approaches, what do they add new to it? Right? So they came to a conclusion that one of it was reflexes and synergies are used to facilitate function in all these approaches. That's Bobath, Brunstrom, PNF, Roots approach. All these approaches used some form of reflexes and synergies in order to facilitate function. Second one was, in most of them, a developmental sequence was used in order to train them as they went across period of time. And then reciprocal movements were used in most of it. So in PNF, we know about D1 pattern and D1 flexion and D1 extension pattern. That's a reciprocal movement. A similar patterns were used in other approaches also. The next one is sensory stimuli are used along with these facilitational movements. They had also a lot of sensory stimuli being given, and resistance was provided to all the movements. Okay, right? Although most of it was a very physical approach, all the approaches underlined and stated that motivation of patient is very much necessary, that patient has to be actively involved in the treatment and he has to be trying much while the movements are being performed. Okay. And finally, coming to the last week of the session, we have they reviewed all the teaching of therapeutic exercises which was at that time, and they created new definitions and objectives for the curriculum. And then once they developed the objective for the curriculum, they developed the course content and designed the final curriculum. And they had a discussion, relation between the course objective and the content, does it match with objective? And they summarized everything. Okay, right? So this happened over a period of 20 days. And you can see here the objective of one of the objectives from the session. The student is to develop an understanding of normal posture in it. In order to accomplish this, the following specific sub-objective must be fulfilled. The student is to develop understanding of the integrative function of the nervous system, reflex pathways, and so on and so forth, right? So the special part about this conference was there were a lot of question and discussion periods. There were film theaters. They had brought in films of normal development of patients. They had brought in from different places, not just from the speakers, but from different places. There were group sessions and review of past weeks. Okay, right? So these are some of the experts. The specialty of this conference was that people from different wakes of field have come together. They were anatomy professors, physiology professors, educational directors, medical directors, course instructors, neurology professors, speech language, OBG, psychologists, PMR professors. And you can see that so many different professionals have come in. They all had contributed in order to develop an understanding of what should be, what is the physiological basis of all this and how we can apply it. And the educational directors and medical directors were not from the field of physiotherapy per se at that point of time. They had also been invited during the last week in order to tell them that this is the curriculum. And at that point of time, there were around 48 schools of physiotherapy, and of them 46 had participated. They had invited two teachers from each of the institutions. And even from Canada, they had invited 8 schools. And the deans of all the colleges were invited for the final week. Okay, right? So that brief of the New Step conference where it all started. So thank you. And if just one second. Yeah, I think we are just well gone beyond time. So without further delay, I would like to shift it to Vipinnath sir, who will now take up the second step conference and what it entitled. If there are any questions regarding it, please keep noting it down. We will take it up if time permits at the end of it, or we always have a chat group and things and we can take it up. Thank you so much. I'll now stop my presentation. Vipin sir?
Yes, sir.
Yeah, please, you can start sharing. Thank you.
Hope my screen is visible.
Yes, sir, it's visible.
Yes, sir.
So, second step actually took place in 1990 from July 6th to July 13th. That it was a 8 days program compared to the step one or the new step, which was very long. Okay. So, and the venue was Oklahoma University of USA, and there were around 400 physiotherapists. Okay, and predominantly from the US and Canada. And this funding was provided from the pediatric section and the neurological section of American Physical Therapy Association, and registration fees of participants. And the profit, the idea of the second step is the profit from the program will be used to support the education and research related to the pediatrics and neurology. So the main purpose of second step is to bring new theory and new knowledge arising from the same content areas addressed at the new step. So second step is the continuation of the new step, okay, to an audience of physical therapy educators who work in both academic and clinical settings. The specific objectives, there were 11 specific objectives. First one was to describe the criteria for a theory and discuss how theories influence clinical practice, and describe several types of theories, differentiate among motor learning, motor development, and motor control, and outline the stages of motor learning, and list the issues in motor development across the lifespan, and describe how current theories of practice relate to contemporary theories of motor control. So this point was the transition from reflex theories to the um, task-oriented theories that we can see in the studies. Next, describe quantitative and qualitative measures of motor performance. So how the motor performance can be measured, and discuss how learning, perception, and motivation affect motor performance. Describe clinical application of contemporary theories of motor control to individuals with developmental and neurological deficits, and also to list specific assessment and treatment techniques of motor function in individuals with Parkinson's disease, cerebral palsy, hemiplegia resulting from CVA, spinal cord injury, spina bifida, Down syndrome, and brain trauma. So if you see this, it's clearly evident that they are focusing on the all the neurological conditions, starting from the pediatric to the adult. Okay, due to accidents, also stroke, okay, and other pathological conditions like Parkinson's disease. So the participants, as I mentioned, there were 420 participants, and majority were there from the clinical side, and the remaining from the academic faculty. And 1% of the participants were from the occupational therapy and other fields of medicine. The registration of the participants, preference was given to the educators and members of neurology section and section of pediatrics of APTA, that is American Physical Therapy Association. The registration was full in very few weeks, and there were people put on waiting list. Okay. And if at all there were any cancellation, they will be permitted like that. And the speakers represented the areas of motor control, motor learning, and motor development. And the thing is, most of them were physical therapists. The supplementary materials and program aids were, several speakers provided handouts of the conference, and which the content were like their outline of their talks and the references for further study. There were videotaped sessions, okay, but was not, we were not able to view it because it was not replicated for the publication. So we were able to see only the papers which were published. The conference actually began on Friday, 6th July 1990 and continued to morning of Friday 13th. As I said, it was a 8 days program and the timings were from morning 8 a.m. to 5 p.m. In the first 3 days, they were focusing mainly on the theories and its importance, followed by the presentations of contemporary motor control and motor development theories. Contemporary means at that time, that is in the 1990. So that was almost after 24 years from the new stuff. On the fourth day, traditional and contemporary theories were presented with an eye toward merging the concept. The attempt was made to merge the concepts from the reflex theory and also from the systems theory. Small group meetings for discussion were conducted on daily basis. After the conference, there were small group meetings so that the speakers and the participants and all, they were able to discuss in detail. On the fifth day of presentation, there was papers on the measurement of motor performance and abnormalities of motor behavior. So this was followed by a presentation on the recovery from the brain damage. On the sixth day, cognitive and perceptual factors in the motor control were discussed. And on the seventh day, assessment and treatment of common neurological disorders were discussed. As I mentioned, the developmental from the pediatrics and adult neurology conditions were discussed. On the final day, it was devoted to presentation on functional skills in the context and the discussion of action steps that should result from the conference. So they were discussing like what should be done in the future. So the conference ended with a summary address. So there were also special events for the entertainment. So there were two speakers on the opening remarks. Okay, that was like they were revising what was happening in the new step, and they were welcoming all the participants of the second step and thanking the members who organized second step. There were also another opening speech, like describing about the new step and the second step, and they were describing about the participants and describing about the funding and about the planning committee and comparing and contrasting the objectives of the second step and the new step. So I have selected some of the papers. There were almost around 20 to 25 papers. For that, I am like skip some pediatric papers which we can discuss later on. So I'll be discussing only some of the papers which I thought to be very important, which focus on the transition from the new step to the second step. So there was a paper on defining what is theory. Okay, so this is the starting point of everything. So how a theory, it is a idea or collection of ideas used to explain physical or social phenomena. So we need theories for the development of our profession, or like in order to improve in our treatment plan. We need new theories which are better than the previous one. So any theory, when it comes, it will be facing challenges, okay, which will be overcome by another new theory. So this is one very important paper, okay, which was titled like Assumptions Underlying Motor Control for Neurological Rehabilitation. This was by Horak. Okay, so here you can see in the picture, in the first line you can see reflex, hierarchical, and systems. these are the theories on which the treatments were based. So during the time of New Step, mainly they were focusing on the muscle re-education that was being practiced, and this neurotherapeutic facilitation was discussed at that time. So this neurotherapeutic facilitation was mainly based upon the reflex theory and the hierarchical theory. So later on, this systems theory came, and the focus shifted from the reflexes and the nervous system to the environment and the other factors, okay, other than the nervous system. So that's how the shift has taken place. So if you see here in the reflex model, the focus was mainly on the control of muscle activation, how movement can be elicited in the, or like how the tone can be normalized, and that will automatically lead to normal movement. That was the assumption at that time. So in the hierarchical model, the goal is to control movement patterns, and in the systems model, the goal is to control motor performance in a behavioral task. The importance of function and the task is being introduced here at this point of time. So you can see here, these are the graphical representation of the reflex model and hierarchical model and the systems model. So this reflex model and hierarchical model, if you see, it's like mainly showing about the nervous system. And when it comes to the systems model of motor control, you can see everything, all the systems, okay, revolves around task codes. Okay. That is like we move in order to perform any task. That idea is being introduced here. So in the same paper, the aims of different treatments and the dissatisfaction of the practitioners were being discussed. Okay. So the muscle re-education, neurotherapeutic facilitation, and contemporary task-oriented approach were all discussed on the aims and their dissatisfaction. The next theories of motor control, dynamical systems theory was discussed. So this dynamical systems theory moved away from the reflex theory that most of us know. So here they suggest to analyze transition of movements, okay, and break down into movements. So when there is a very stable behavior which is being challenged, the individual learns how to do new movement patterns. That is what they mainly described here. And there was a paper which discusses how theoretical framework biases the evaluation and treatment. So when someone goes into one approach, okay, it can lead to biases. So how this paper discusses the traditional and current theoretical constraints that underline the neurotherapeutic techniques. That is, they were discussing about the treatment techniques which were based upon the reflex theory and the task-oriented approach. So there is another paper, motor learning principles for physical therapy. So this topic describes two things, that is practice, scheduling, and feedback. So this terms like practice, scheduling, and feedback was introduced in this paper. Next paper was designing practice for motor learning and their clinical implication. So the learning versus performance and neurotherapeutic exercise were discussed here. That is, the main concern was some people perform better and immediately, their performance or the improvement, what we see, declines immediately. So why this happens? So that's how the learning is something which leads to permanent change, and performance is a temporary change. So that is being discussed here. So how This transfer of training and part training, everything can be done to improve the motor learning. That was being discussed here. Then this was a pediatric paper, so I have left it. And this is another one paper, like we all know about the developmental sequence. That is the thing which have been discussed in neurodevelopmental therapy or the roots approach. That is the developmental sequence. That is from the rolling, thrown on elbows, quadruped, then sitting, standing, walking. So this whether this sequence should be used in order to treat a patient or not. That was the question being arised. So, for example, if there is a sequence like A, B, C, which is not normally, okay, we say it is normal. What happens sometimes the reverse also can be seen. Sometimes, it will not be in a one after the other. That can be overlapping also. These capacities are developed on the basis of demand placed on the individual or the child. When the child is developing, it responds or it develops a set of posture due to the demand placed on that. So there is no clarity that what is the first item in the developmental sequence. This was the one question arised against the use of normal motor developmental sequence. Second one, it is not clear whether an item is needed for a next item. So something like, crawling is whether needed for walking or not. It was not clear. Okay. Overlap of sequences were observed. So whatever the sequence they are telling, sometimes there will be overlap. And some items need to be co-occur. Some items occur at the same time. Hence, the use of developmental sequence should be questioned. So another question, another paper which was discussing whether the developmental sequence can be used as the model for pediatric patient, and another was on the adult patients. Again, the same thing. So they were questioning the use of using developmental sequence because they didn't find it very important. Okay, and it can be used only if one activity, okay, if it is necessary for the subsequent activity. Something like if in the sitting, if the neck control comes, okay, that is aligning the neck straight to the body. If it is there, that we need it for the standing also, something like that. If it is only if it is required, then we need to use the previous sequence. So this sequence, if you see, they say that it is there is a number of the joints involved is used, and also base of support is reduced and raises the center of gravity from the ground to the higher level. In supine lying, the center of gravity will be lower to the floor, and the base of support will be more. When you come to further in the sequence, that is sitting, okay, the base of support will be still less. Okay, when coming to the standing, that is the last one, the base of support will be minimum and the center of gravity will be higher from the floor. So that was another pediatric study which I have skipped, and this was like merging the neurophysiological approaches with contemporary theory. This is another one paper. So where the treatment approaches like Feldenkrais method, and that is awareness through movement. Okay, this is a one new form of learning method. It's error here. And neurodevelopmental treatment and sensory integrative therapy and TNF and roots approach. These treatments were discussed, trying to merging with the contemporary theories. The concluding remarks were like to include basic sciences in the further research in physiotherapy and recommends adopting a functional systems approach, detecting a problem areas as system defect, and treatment should be handled by an expert in that system. And approaching a problem-oriented approach, primary emphasis, and client is viewed as a total system. The treatment procedures would be based on the best available knowledge and the client's individual unique differences, and responses should be addressed. So the problem here with the neurotherapies or the facilitation approach, okay, the thing is they were not focusing too much on the task or the functional aspect, okay, of movement. So here, in the concluding remarks, they told to use an approach where all the systems will be systems involved in the patient will be analyzed for detecting the problem areas. There was another paper which was framework for the measurement of neurological impairment and disability. So this was insisting on the overview, like how the problems, okay, should be measured. So this was mainly based upon the outcome measures, and at that time it was not ICF, it was ICIDH, that is International Classification of Disability and Handicap. And abnormalities of motor behavior. This is another one paper. Okay, this paper discusses the definition of motor behavior and what is done in neurological examination, and the neurological mechanism and muscular components resulting in abnormal motor behaviors like spasticity and the use of outcome measures, and summarizes with the need of a golden standard measure for assessing motor behavior. So they were mainly stating that, okay, what is a normal behavior? Because the movement pattern can be of any type. So there is no golden standard measure in order to compare and measure. And there was another paper. This was about the neural plasticity, okay, and also the non-plastic factors that influences the recovery of a neurological condition. So this paper also introduces the fact that recovery of neurological condition is not limited to initial stage. So this was the belief from that time. Okay, so only in the initial 3 to 6 months, the patient recovers. After that, it is plateau. But after the development of researches in the field of neuroplasticity, this fact, okay, this thought was being changed. Okay, so they also insisted that changes happen in the patient. That is, recovery can happen in the later stages also, even though there can be a period of plateau is reached. Okay, the period of plateau can be later on followed by a period of recovery, but it will not be very fast as the initial 6 months period. So another paper was there discussing about the perceptual issues in the motor control. So this paper defines the perception and distinguishes between the sensation and perception, and introduces psychological theories of perception and learning and perceptual issues. The role of perception in motor control and learning is discussed with feedback and feed-forward mechanisms, and perceptual dysfunctions and perceptual recovery were described. And the paper concludes with relating perception, motor control, and physical therapy. How the perception and motor control is related and how it can be used in the physical therapy practice. So there was another paper on this thing, psychological aspects. This was a pediatric paper, so I've skipped it. And next paper is on the Parkinson's disease. So this paper generally started with how what is Parkinson's disease and how the clinical symptom, what are the motor and non-motor signs and symptoms, including posture and gait. What is the abnormality? Okay, They were describing that, mainly about the hypokinesia, and also gives the implication for clinical practice by the classification and evaluation and how to improve the neuromuscular control, the importance of task complexity and adaptive movements, conditioning approaches, and instructional set and intersensory feed forward. Intersensory feed forward is something like, we are giving a warning or like a auditory cue or flashing a light or something like that. Okay, before something happens, if the patient is going to fall or something, that is what. And facilitation, and also the use of treadmill facilitation. What is the use of treadmill for facilitating gait, and also the use of functional stimulation. There is another paper on stroke. So how this physical therapy assessment and treatment can be done. So they were describing initially what is the stroke and their impact, and how we can use the outcome measures and how to evaluate the impact. The therapeutic models, such as compensatory model and facilitation model and motor control model, were discussed. And the studies done to determine the effectiveness of treatment approaches were listed, like comparing the Bobath and other treatment, okay, which were predominantly used at that time. They were the studies done to compare the effectiveness of each approach. They were listed, and these studies were discussed on the basis of selection of subjects, variability of rehabilitation potential, classification of deficit, and spontaneous recovery versus recovery resulting from intervention, outcome measures used, and variability of the programs study design. This study concluded by admitting the fact that not all patients have the same probability of achieving motor recovery after stroke. So hence the physiotherapists have to take active role in identifying who will benefit from which treatment. There were pediatric papers, which I have skipped, and there is another paper on the head injury. This paper examines the management of adult patients with head trauma by describing the pathophysiology, such as primary damage and secondary effects. This paper also discussed the issues of interest to the movement science, such as motivation, automaticity, application of motor learning principles, and what is important for future research. So the paper, spelling mistake here. Okay. So the paper closes by emphasizing the need for caution in setting goals for patients with brain injury. The focus should be the society integration and to improve the quality of movement. So in the physiotherapy, we are mainly focused on improving the quality of movement or even the function. But that is not, that much is not sufficient in case of head injury patient. We have to integrate them into the community. Okay, that is what the paper comes. And this is a very important paper on the last page. This paper highlights the importance of functional significance. As I mentioned, all the reflex treatments, that's facilitation approaches, we were focusing only on how movements can be initiated and controlled. They were not focusing much on the functional aspects of the movement. So this paper was mainly focusing on. So so instead of normalizing the muscle tone or improving the gait symmetry, there should be importance should be given to the functional independence of the patient. This paper further discussed the development of functionally oriented treatment goals and how to formulate specific therapy objectives and involvement of clients and caregivers in goal setting and measuring of functional changes as a result of treatment, and use of adaptive equipment to accomplish functional goals and generalizing functional goals across different environment systems. The facilitation approaches fails to address the functional carryover and functional needs of a neurological patient. So that's the conclusion. And I think that is the last paper, and afterwards, there were discussion on the future. So that much about the second step. So hope I made it clear. If there is anything like you can ask me, if it was not clear.
I think it was pretty clear, and you had elaborated on almost all the papers. So I think it was pretty clear on. So now we'll move on to the next session. Selva sir, please take over, sir.
Sir, can you see the slide?
Yeah, it's
Yes, sir.
visible, sir.
Yes, Selva.
Yeah.
Can change
So-
it to presentation mode.
Yeah. Now is it in a presentation mode?
It is in the normally we prepare slides like that. It is in that format.
Slideshow button, can you?
Slideshow, yeah. Put it in
Yes.
slides.
Yeah.
Okay, I put the slideshow. You can see
You can press Shift plus F5
Shift
plus F5.
5. Now,
No, sir.
It's not coming. Can you just once again try pressing the last button, sir?
okay, sir. I think I'll go back again. I'll stop sharing and again share it.
Yeah, please.
Okay. Now, sir.
We are not able to see your screen, sir.
Okay, now I think.
Sir, can you once save the PowerPoint?
Okay.
So your file, can you just press it, save?
Yeah, just send it to. Recently, just send it to. I'll just send it to somebody.
No, sir. You can just try
Hello?
this. Save button. You can press it.
Okay. See.
So should I present it from this side?
Yeah, actually, I made some slight changes, and nevertheless,
Okay.
do that.
Yeah. Sir, now I think, sir, near that there is a 49% right in the right
Yeah.
bottom. Next to
Yeah.
that there is a slideshow button that you
Yeah,
can press, sir.
I did that.
Yes, sir. Still it's not coming.
No, screen sharing, I think it's not done so far.
Sir, can you
No, sir.
share
Like
this?
we were able to see that before. So I think.
Earlier, I think you
Yeah,
stopped
yeah.
it now.
Okay. Okay.
Yeah.
Now you're.
Yeah. Yeah. It's correct now. So,
Okay.
Yeah.
So this step 3 conference was done in 2005, July 2005. The main objective was translating evidence into practice. It is also the linking research into the clinical practice. And more emphasis was on neural plasticity and also the framework, like from ICIDH model to the newer model. There is framework for considering function and health and the disablement process. So many conditions and case studies were presented in Parkinson's and also in spinal cord injury. So I have made it for a quick information of each article and then some slight elaboration on each condition. I think I can. The first article is on cortical reorganization following bimanual training and somatosensory stimulation in cervical spinal cord injury. So, so this case study was presented. The main finding was like intensive training or intensive practice along with somatosensory stimulation has not only improved the function, also there is a change in the cortical map area. It means the cortical, they use the TMS to measure the cortical area changes by the motor threshold, what they have elicited with the minimal stimulus, what's the best response elicited. That was now from the beginning, it was posterior and it was moved to anterior in the later part. So then that way they could prove the neural plasticity aspect also. It is not only the function improved, and as well as the changes is happening in the system. And also in elderly subjects, this was just a review to find out whether this loss of sensation in the proprioceptors, whether that is contributing to the falls. And they concluded that there is a nominal evidence is contributing for the loss of proprioception for balance issues in elders. And also they have emphasized for any sensitive measurements tool to measure such things. Even though they used certain tools, and they found that the sensory system is affected earlier than the motor system. And also very importantly, integrated framework for decision making in neurological physical therapy practice. This is based on the guide to physical therapy practice. I think most of us are aware. That's where they have come out with the terminology, or we can even use the word physical diagnosis, like the word like stroke or a major pathology is not actually giving any meaning to the physiotherapist. So they have come out with some different terminologies like motor protection or muscle force protection problem. So when we describe it in such a way, so the therapist can actually make intervention better. So in this they have incorporated many models, including this enablement and disablement perspectives, that is from Nagy model, and hypothesis generation. I think this article on hypothesis oriented algorithm also. And they have also given sort of guideline for overall how to approach a patient, how to form hypothesis, and then based on that, how do you design your intervention, which includes what type of assessment tool has to be selected. And the main important finding is they moved from the patient, impairment perspective to the patient perspective. So more of patient-oriented approach was emphasized in this model. I think, hello.
Yes, sir.
Sir, you are audible, sir.
We can,
Yeah,
can follow.
okay, got it. Yeah, and then another article on whether the passive methods, I think that's the time that even robotic therapies have been introduced. So so they found out whether that using robotic based training versus the therapist assisted training. So then they come out with an conclusion saying that robotic assisted therapies are not making much differences. So the passive guidance therapies needs to be discouraged and more of active training has to be done. So they found that in the metabolic cost as well as the surface EMG activity was the threshold was reduced. So when the robotic therapy was used, then the Parkinson's patient, they have used the ICF model. This is the time that ICF model was introduced, I think from ICIDH to ICF. So in that, how do we fit that model into the particular conditions like Parkinson's. And also they have emphasized in phase wise, like in Parkinson early, moderate and severe stage, how to select the interventions. And at the later stages, they emphasized more on the environmental modification. And another important article is on that neural plasticity after spinal cord injury and training, and emerging paradigm shift in rehabilitation and walking recovery. So here they demonstrated, like, even with the stimulation of the CPG at the spinal cord through the stretch reflex of the hip extensors, as well as the ankle extensor, that is loading of TA, tender Achilles, or the plantar flexion. Those two actions can elicit stepping actions. So also they have emphasized that when the treadmill training is used, it's better not to give the arm support, because that changes the overall the movement protection. So it is not more natural movement protection, because there is other it modifies the overall mechanism. So they have emphasized the harness can be given, but not hand support. And stepping can be elicited by encouraging that hip extensor stretch reflex, as well as loading of the ankle, that is plantar flexion action. Now this is another important, this is by Mark Latache. So synergies in health and disease relation to adaptive changes in motor coordination. So they emphasize the uncontrolled manifold hypothesis. In fact, they come out with this, and so they say that this can be used for measurement of synergies. And so here, in contrast to the previous model, they emphasized on motor abundance principle. So see, earlier to this, the norm is like, if there is a motor variability, which is not good. And but then in this model, they have emphasized the motor variability is actually good, which can be utilized to develop the new skills using the neural plasticity. So so there's a scope for evaluating the change in the synergy under the context of neural plasticity in neurological disorders. That was the conclusion in this hypothesis. So we'll slightly see all these things in detail later. Then interpreting changes across change score of tests and measures used in physical therapy. So here they emphasize that even though there is clinically there's an improvement, but then which is not actually important for the patient, or which is not really meaningful for the patient. So they have emphasized that even though this minimal clinical changes can be seen, but it is based on, it can be on anchor based, preferably an anchor based. Anchor based is we have to keep a patient, family member, or even clinician can be a stakeholder to decide on what would be the critical thing which is very important for the patient, and that can be utilized, so that the differences what we see, we can correlate that for the meaningful clinical as well as functional activity. So any research, when we report it, it has to be better reported with MCID, and that is minimal clinically important difference, or minimal important differences. So but then they also say that when the scale is developed, so it is better to use this item response theory model, wherein each the scale can be divided into different aspect of person's function, so we can see the differences accordingly. And the ICF model we'll see little later. Then also this conference, basic science people were participating, and their perspective also shared. So now we can go ahead with the slightly detailed version of this. The first article is on cortical reorganization. They used a C6 tetraplegic patient with Asia-B type with hand impairment. So the intervention is mass practice of bimanually daily life task with electrical stimulus at a median nerve. The pictures are shown on what are the practice undergone. So sensory stimulus were delivered at frequency the whatever it is mentioned here. So overall through to 2.3 milliampere was the average stimulus intensity across 15 intervention days it was given. And the outcome measures was in the motor manual muscle testing of key muscles on Asia motor scale was performed, and Jepsen-Taylor hand function test and Cherokee arm and hand activity inventory. Sensory function was measured using Asia sensory score and another using this monofilament test. So it's not only the patient improved in terms of sensory and motor function with the repeated mass practice as well as the sensory stimulation. So the patient also reported improvement. So in terms of the daily functions, the patient reported improvement. And this second article is on aging of the somatosensor system. So they say that there's accelerated decline in overall sensory systems, and it's predominantly seen in the large myelinated fibers and associated receptors, and also impaired proprioception, vibration, and discriminative touch, all of which are rely upon large myelinated afferent fiber functioning. And age-related involvement of sensory fibers occurs earlier than motor fibers. And they concluded that very nominal evidence only existing linking the impaired proprioception and cutaneous sensation in the lower extremities with balance dysfunction in older adults. So this is the integrated framework for decision making in neurological physical therapy practice.
Sir, Selva, sir. Yeah,
Hi.
1 second, sir. I thought we will have maybe further sessions. I thought we can take a one-on-one conference and we can go slightly more into depth with. But this paper which you are showing now, which is an integrated approach, is very important. So I want you to summarize this. After this, we will move on to the next session later, John.
Okay. Sure, sir. So now I think again I made it very simple. So I'm not going to explain with one by one. So in this chart, we can see start from interview with the patient or history taking. From there, you are going to find out the enablement and disablement, like what is the patient's can do, what are the positive aspect of the patient, and what are the difficulty the person is facing, and then you based on that, now you decide on what are the systems to be evaluated. So systems review you will be doing. So further you can actually this can be based on the impairment. So it can be cognitive assessment or it can be motor assessment, all will be decided, as well as the based on the function we can decides. So here they use the Gentile taxonomy, like whether the subject's interaction with the environment, that based on that context the assessment has to be done. It means the patient has to be made to walk on the regular surface and in a moving environment, or the people going around. Likewise, in a different environment, this task has to be analyzed, and in the task also you have to see that the initiation, execution, and the termination, whether all these three aspects is the smooth movement is there or not. So based on all of these aspects, you come into a conclusion that what kind of problem the patient is having, and then you modify this your hypothesis and based on the patient's response to it, and based on that you can decide about the interventions. So I think further maybe we can, I think these are the details of that. So I think we'll stop here.
Yes, because these ones are very important. I think bit
Yeah.
detail we may need to sit and discuss about it.
Yes.
So I think we'll try and
Okay.
have some other sessions where we
Sure,
are
sir.
going deeper to it.
Sure, sir. Sure, sir.
Thank you. Yeah,
Okay.
thank you,
Okay.
sir. It was a very elaborate and a very clear presentation of what has happened in the third step.
Okay. Thank you.
So thank you.
I'll
Yes,
stop
you
sharing.
can stop sharing. Yeah. So now we'll move on to the most interesting part, which is the current practice. So this happened in the fourth step conference. I would like to invite Sheikh Abdul Qadir sir to present about the fourth step conference. So your mic is muted, sir. Can you please unmute and speak?
Sharing my video. Okay. Am I audible and is the screen visible?
Yes.
Yeah. Okay.
Yes, sir.
Yeah. I am. I don't know. Like we'll see. I have made it in a way where not going into the details of each and every paper, but taking a concise of this. I am trying to take it. I have tried to make it brief, and I think we are already running a little bit late of our scheduled time. We'll see. Okay, there's a fourth step conference. I will be covering most of about the adult neurorehabilitation, whatever the themes have been discussed. It has been held at the Ohio State University, which is in the Columbus. It had held for the 5 days, and my habit of talking fast is there. So if anyone is there, if anyone is not comfortable, or if anyone is not able to follow me, please stop me and then and there, and you can ask me to slow down. I
So
can
you
do
can
that.
you can go at your normal speed. It will be more
Okay.
understandable.
Okay. So what was there in the fourth step conference is the planning committee of the fourth step conference had asked all the speakers, or the scientific committee or the planning committee had made it clear that the speakers should incorporate their presentations or their views. It has to be presented in a way which encompass all the 4 P's, which is prevention, prediction, plasticity, and participation, because they had come to that conclusion over the years that these are the 4 P's, which is at that point of time, at this point of time, where it makes major impact on the neurophysiotherapy practice. So they had made it quite a point to the, even before the conference occurred, they had made it a point to tell their speakers to make their presentations based on these 4 P's. I will just describe about the 4 P's in brief, what we know and what has been explained or what had been done in the conference. I would be going a little bit in detail. First of all, if you are talking in terms of prevention, we all know there are 3 types of prevention is there, which is like primary, secondary, and tertiary prevention. Primary prevention is such that, like, where we can prevent in a typical individual or in a normal healthy individuals, where we can where we can intervene and where we can prevent some specific diseases or disabilities, or to a high risk group where we can do it. For example, if a pediatric or if a kid with obesity, if he is more prone for any non-communicable diseases and all, we can have some health promotion strategies, so that their specific diseases can be what we can say, can be prevented. This comes under primary prevention. And recently, even the WHO had framed certain guidelines, which has been incorporated in this, which has been emphasized in this fourth step conference also, where they had the physical activity has been greatly emphasized, not only for the disabled or for the people who had with some impairments or with some disabilities, even for the normal individuals also, or the unimpaired individuals also, the health promotion has been highly emphasized. And secondary prevention is where we have, for example, if we are treating a stroke patients where the chances of stroke recurrence is higher, or for a patient who can develop some other comorbidities because of pathological changes which they are happening, then whatever we do for that to prevent is comes under secondary prevention. So tertiary prevention is what we do. For example, if we teach some fall prevention techniques, or some training program which we frame to to prevent some disabilities in in a already disabled patient. The thing which has been there is, we physiotherapists, or the in a worldwide the physiotherapists have been more involved in tertiary prevention rather than in a primary or secondary prevention. Probably we have went up till secondary prevention to quite some extent, whereas we have a huge role in the primary prevention. Second is prediction. Prediction is one of the very one of the very important theme which has been emphasized in this fourth step conference, where the prediction is doesn't means like how a person will prognose, or it also includes what would be the optimal response to intervention. Because if a patient come to us, we should be knowing what kind of treatment we are offering and what would be the optimal response to that intervention, that we should be knowing, so that we can predict and we can frame our goals accordingly. So that we right now we have certain parameters which we use in our daily practice or in our clinical practice, like gait parameters, like gait speed or endurance, or there are certain things like if in terms of CPS, cerebral palsy, where we are using the gross motor functional classification system. All those things will give some rough idea, like how much the person can improve, or what are we dealing with. Third is plasticity. From probably from the third step conference, the neuroplasticity has been given very undue importance, and even in the fourth step conference, a huge amount of importance has been given to this neuroplasticity, in which we know which is nothing but the neural circuits have the ability to change, not only structurally and as well as functionally. As Selva sir has mentioned, like to enhance neuroplasticity, balance training and treadmill training and all has been started, and it has been in practice. Third is the fourth is the participation. As a physical therapy profession, I think we lack quite a bit in this domain, where our focuses or emphasis focuses majorly on impairments, and to certain extent on to a certain extent on the activities and activity limitations, whereas participation domain has been grossly neglected, I feel, even till date, because systematic review examined what are all the interventions which is aimed at improving participation as the primary outcome. They were able to find only 3 studies with that. So this is how we have been in this 4 Ps, and in the conferences how these 4 objectives or these 4 Ps has been explained, that I will be talking a little bit more on. Before that, they are also describe about this, how this is not this plasticity, participation, prevention, and prediction. All these things have some interdependency, because based on the participation and prevention measures, we can enhance the plasticity, which in turns will give us some idea about the prediction. Prevention, if at all we have to, as I had mentioned in the prevention, where we physiotherapists can focus majorly on the modifiable risk factors, where our patient population, it has been heavily emphasized in the 4th step conference, that physiotherapists should have an active role in modifying these modifiable factors, such as like diabetes control or hypertension, smoking, depression, physical inactivity. This is not only for those individuals who had already sustained, for example, a cerebrovascular accident, or a patient with some neurological disorders like Parkinson disease. This has to be emphasized to each and every person, even healthy individuals, even to that extent, from the school-going kids, from the pediatric population without any disabilities. This has to be emphasized, and this is a huge role where physiotherapists should utilize it, because that is one thing where we physiotherapists having a good knowledge about the interventions what we are giving and these movement systems, and if we are incorporating it in the health promotion, probably we will have a better community, so that the occurrence of impairments or occurrence of the disabilities itself can be reduced. This is where one of the things which has been highly emphasized in the fourth step conference, where the physios have to work upon the health promotion via primary prevention. As I had mentioned, they had mentioned about this ACSM guidelines of 150 minutes of moderate intensity aerobic exercises or 75 minutes of vigorous aerobic exercises. This has been seconded and have been recommended by the WHO organization also in the recent physical activity guidelines. And this it includes 2 days per week for strengthening exercises and balance exercises of 2 to 3 days per week. The recent WHO guideline had said exclusively this includes not only for the people without any disabilities, even for people, even any individuals, any disabled individual can be adapted to that, but accordingly to their status, we have to modify it. This is just a output, just a flowchart diagram of how a physical activity can work even in a person with disability. If the physical activity will increase the cardiac output increases the cerebral blood output, that thereby increasing the output to the brain and thereby increasing the angiogenesis, synaptogenesis. All these things will comes under our neuroplasticity enhancement. Thereby our motor command and the motor control will improve. So regular engagement in physical activity can serve as a powerful strategy to promote health and well-being, not only in neurological disorders, but also in any children, youth, and the adults. What we have to focus more on is the accurate and reliable measurement of physical activity, and that has to be monitored, because monitoring of the patients who with undergoing physical activity, this is not going to be an one-day process. So there has to be like continuous monitoring, and the motivation has to be kept, especially for an neurological disorder patients. This has to be kept in mind. It is not like that where we had giving our therapy sessions at the clinics, that won't be sufficient. So remote monitoring like telehealth or wearable sensors or web-based platforms has to be utilized more to enhance adherence and therapy durations. They have discussed about this utility and how it has impacted on the stroke patients' outcome had been discussed in one of the articles. Secondly, a prediction. When it comes to prediction, they had said in this fourth step conference, a major emphasis has been given for the movement system diagnosis. I will take some time to explain this, because it is one of the one of the parameter where they had given an undue emphasis on this. The movement system diagnosis must what they say is as a physical therapy profession, we must be able to come to something called as a movement system diagnosis. That diagnosis which represents movement system disorders, and that disorder is not like, as Selva sir had said, it should not be like something like stroke or anything else, but it should describe about the where the patient stands in terms of the signs and symptoms of the disorders. And the diagnostic label should be short, it should not be a very lengthy one, and it has to be as a well accepted terminologies. From the physical diagnosis or the physiotherapy diagnosis, in the fourth step conferences, they had proposed this as movement system diagnosis to make the diagnosis to be universal, and so that the other professions can also use it and utilize it, and so that this can be a worldwide with a wider reach. All forms of research appropriate, where this has to, they had emphasized that the researchers has to be appropriate so that they can identify and validate the movement system diagnosis. What they had said it as a movement system is it is not only about the neurological and musculoskeletal system, but they had the movement system encompasses of all these essential systems like endocrine system, nervous system, cardiovascular system, pulmonary system, integumentary system, as well as our musculoskeletal system. Other thing which is why this movement system diagnosis or movement system has been given more emphasis is, as we all know, pathokinesiology is nothing but there is some pathology in the human biology which is resulting in movement disorders. That is what we can say, because for example stroke had caused them, a cerebrovascular accident had caused some movement disorders. However, the emphasis is also should be made on kinesiopathology, which is like the disordered movements that can result in pathology. So it has been emphasized that as physiotherapists we have to understand what are all the disordered movements that can end up in more pathology, so that we can prevent it. For example, if a medical diagnosis is stroke or hemiplegia, there is one of the speaker who had published a paper, and they had said like movement system diagnosis can be, they had given 3 case studies for the same diagnosis of the stroke with the hemiplegia. There can be a force production deficit in which the person cannot able to produce the force, and second can be fractionated movements, what we call it as the isolation of the movements, that cannot be done. So it can be designated as a fractionated movement deficit or the perceptual deficit in like a pusher syndrome, where the patient is not able to we're having a problem with the perceptions. So what they had said is, rather than coming framing something as a with the going with the medical diagnosis, we physiotherapists should be able to come with a medical movement system diagnosis, such like force production deficit, or where the deficit is there, so that these diagnoses will guide us towards the therapy, as well as to research, as well as the education can be directed accordingly. This is, I think, this was the paper which which has been emphasized in the third step conference also, was sir was saying. What they had said is a movement has to be in the movement continuum, everything has to be checked upon. I think we will be discussing this in detail. So I would like to say what are all the tasks they want the fourth step conference had emphasized upon to look upon, rather than saying only about the joint movements and the muscle powers. As a task for the movement, they want us to observe in terms of the, there are around 6 movements they had emphasized down. It is sitting, standing, sit to stand, and stand to sit, walking, step up and step down, reach, grasp, and manipulation. All these movement has to be observed in these terms: how the patient is initially doing, how he is able to do it, whether he is able to initiate it, execute it, terminate it, whether the intended outcome is achieved or not. Human movement variability. There is one other paper which I personally felt this is a very interesting paper, which is about which talks about the multifractality, adaptive capacity. For example, if we are training a patient to do sit to stand, there are 2 ways what we are assuming in our mind, that one thing, either we do it as a linearity, where we will ask the patient to do in such a way go forward with your shoulders until till this level, and then you get up on your own. This is how we will say the patient a correct movement behavior, or the typical movement behavior is being taught to the patient, so that we are expecting that the patient will adapt this movement pattern on him, and so that he will be executed in the real life needs. Whereas if we had seen the researchers in the past have shown very clearly, even a typical individual is doing the same activity for a repeated number of times. For example, if you do a sit to stand activity for 10 times, there is a change in each time what we are doing it. So there doesn't seems to be a linearity of what we are do and what we practice will be delivered in the actual performance, whereas there can be a difference in that. So non-linearity is a concept which has been adapted more, but in this they had emphasized about the multifractality. Even though we do something as in a way with variability, which has been which it can be said as a motor abundance, or what we can say, it doesn't, we do it with the human motor variability, that can be explained or researched upon via multifractality. Multifractality is nothing but, for example, they had done a study in which they had asked the patient to tap the finger whenever they are whenever they hear a sound like this. If the patient was able to predict it and do it, if the input is being given regularly, if the input has been varied without knowing, without the patient being knowing, however they have developed a pattern on their own, even though that doesn't sync with the given clue, they have developed a pattern. So whenever we are doing a movement repeatedly, even though there can be variability, there seems to be a pattern which we have to focus more on, which we have to study more about, so that that can be utilized in a therapy or our more understanding of the human movement variability. Sorry for such a congested slide. This is in this they had talked about in plasticity. One of the things which has been majorly one new thing in this fourth step conference is more emphasis has been given for genetic variability. Every patient, or even though there cannot be a mutation, there can be polymorphism. So an individual with a polymorphism is nothing but there can be certain variations in our genetic patterns which will have an impact to our response to the therapy being given. So those two stroke patients with identical functional status, with identical impairments, can behave differently to our therapy. That can be, it can be because one of the factors can be the genetic variation. So it has been emphasized that our therapy program has to be in line with the polymorphism, if at all anything has been existed. For this to be happening, we should be knowing what genetic variation will have what kind of effect in our patients. So the role of genetic variation in the response or to the therapy or motor learning or motor recovery has been highly emphasized. Secondly, there is one another interesting study which has been done which demonstrated about the capacity versus performance. Usually till recently we, or even till now, we are under the impression that more the better for neuroplasticity as well as with the motor recovery. But however, they have done in a stroke patients, especially for the upper extremity training. Once the patient had gone towards the that 6 months period or the window period where the natural recovery, the chances of natural recovery are lesser, that even though there can be a chance, there can be an improvement in the capacity. For example, if you are doing if you are giving a training, the patient will be doing it in front of you, that task would be doing it. Whenever, if we are assessing the same task in his performance, in his real life need, there doesn't seems to be much of a difference. This is one of the very I can say shocking revelation that we had got. However, we have to understand that probably whatever capacity we are building in our patient may not be translated into performance in their needs. This is, at this point of time, it is still only with respect to the upper extremity, whereas in lower extremity it has been the change has been happened even in performances also, regardless of the time of intervention. Meaning, even in a chronic patients, for the lower extremities, the there is change in the performance, whereas with respect to upper extremity, probably we can improve the capacity, but the performance may not be that much. We may not be able to change the performance. In terms of spinal cord injury, one another thing which we have to be more giving focus about is the inflammation. They had done some studies in the mice where they had created, after spinal cord injury, if the inflammation cascade has been happening, how during that time how the therapy will work, and if the inflammation has been stopped by some other means, how the effect of therapy has been, high effect of therapy would be. This they had done a very beautiful study in which they had said, with the inflammation has been happening, where if you are giving the treadmill training, that time it is the sustained locomotor deficits were more than even without any training. That means if there is a neuroinflammation going on, and at that time if you are intervening and giving some training like treadmill training, that time the locomotor deficits can be even worse. If we wait for the inflammation to get subside, and then for example, if the time period had gone, and then if we are given the treadmill training, there was not much of a effect. So the conclusion, or what we can assume from this, is the not only the actual spinal cord injury, but the subsequent inflammatory processes can do more damages, and it can have an impact on our therapy. So our therapy should be bother about the inflammation which has been going on happening also, because just like our genetic variability, this inflammatory processes also can have an impact on our therapy effect. likewise, activity dependent plasticity can be emphasized, can be obtained more towards locomotor training, epidural stimulation, direct muscle stimulation. And they had proposed a scale of neuromuscular recovery scale for the spinal cord injury patients, because the ASIA or the other scales which is available right now may not be able to do about it depends upon the function, whereas it will not about the movement quality. This particular movement neuromuscular recovery scale focus on the movement patterns also. Also, there are certain studies which is done on concussion, which with respect to the neuroplasticity, in which it has been said the physical activity have a clear benefit in improving the neuroplasticity after concussion. Participation, if I have to say, probably in even in a fourth step conference, they have not been able to done much about participation, because there is not much of ideas to improve the participation. We may have to wait for a fifth step conference, or we may have to take some steps to improve this. There is something it has been one other thing which has been very highly emphasized in this conference is what we can do to match this individual needs of the patient. Because if we focus more on randomized control trials, where we have to make a homogeneous group and then it has to be compared with the controlled group, this may not be the case at this point of time, at least. So they have proposed something called as which has been emphasized more is single case design. We should not confuse this with the case report or case studies. In this single case design, it is n of 1 is means a single person will act as his own control. For example, AB design is one that where a person's baseline status has been documented for at least 5 points of time, and then an intervention will be given, and then to see how the patient is been improving, so that and even at the at least 5 points of time he was not changed, but after giving intervention he is whether the person is changing or not, that we can see. This is a simple AB design. Another thing is as an A1 A1B A2 design, where your baseline status in the baseline person will be evaluated, and then the intervention will be given to see the effects, and then the intervention will be stopped to see whether there is any drop down of the improvement made. Like this, there are certain other methods. I don't want to go into the details of this. There are sometimes multiple baseline design to introduce the intervention at different points of time to different participants, so that we can say at what point of time the therapy had a better benefit. This is this been proposed in the fourth step conference because this acts as a effective alternative to the lack of evidences we have for our approaches or for our treatment techniques in our profession. What they had mentioned is they in the future what we can do is, as I had said, it is a personalized thing, has to be done personalized intervention in terms of personalized care has to given to that patient. In terms of prediction, the neuroimaging has to be there, and in terms for that patient, how we can do with the teamwork and partnerships, so that we can have a better health. In terms of the prevention, the genetic component has to be taken care of, and intervention can be in terms of exercises and health promotion, so that the impairments can be prevented. In terms of plasticity, we have to classify the patients accordingly, so that we can intervene better. The motor training can be given accordingly, the intensity can be given out accordingly, so that we can have a better motor output. The participation in terms of goals needed for the patient has to be emphasized, so that they can have a self-efficacy, and virtual reality can be used to improve this participation, so that the patient's goal is being achieved. The take-home message was that we may have to drastically reconsider whatever our dear held ideas in terms of research, in terms of our clinical practice, as well as in terms of our education, so that we have to be open to new avenues, where we have to focus more on how we can go for novel research designs to answer our questions, so that the lack of evidences in the profession can be tackled off. That's the end of my presentation.
Thank you, Sheikh sir. I hope we have traveled 50 years in a period of 2 hours, which is really, really very dramatic, and because of which we had to compress a lot of things. But then it's very interesting, right from left flex model and many of the things which came in the fourth step, and some of it in third step were really novel. I think we have not still started looking into it. It's quite late, so I would like to thank all the participants as well as the speakers who have taken the time to read across vast number of papers and presentations. But before concluding, although it's very late, I would want to say a few concluding words. I invite Vaishnavi to please tell what is the next way forward for us.
Yes, thank you, sir. Thank you everyone for joining for today's session. Am I audible to everyone?
Yes.
So for the content material for the today's conferences will be shared on the registered email to you. So anyone who wants to go through the contents and the papers, and if you have any queries or you want to discuss a particular paper in detail, so you can give us feedback for the same through email and text us back so we can put it forward. And for the next session will be conducted after 15 days, that is on 16th March, that is the Thursday. And in this session, we will be discussing the summary of some pediatric papers, as well as we will be explaining about a website in which we have multiple sources which are related to motor control. And also we have some upcoming events. One of them is the webinar on human behavior change, which is starting from 8th March. I would like Vasant sir to give a brief idea about the webinar. Over to you, sir.
Yeah, I'm sorry. The webinar is starting very early, so I had to inform about it. Last year, we had a good session on behavior change, and I hope we all know that it is going to be an important thing. There is a project called as Human Behavior Change Project, where they have developed a system in order to identify which treatments work better for which systems are going to, which type of behavior change techniques are working better. And this is from UCL, University College London, and it is a free webinar. So we have, it's a 3 months program with every week, 1 hour it is there. So the first week is going to be on what is Human Behavior Change Project. We are going to explain. And this is presented by the top person in the field in the world. It is Susan Michie. She has generated a lot of evidence, as well as she has developed a new science called as human behavior change. And it's going to be very interesting. So please do register for it. We will send you the link in the group, as well as for the registrants, so you can register. And after that, we can have a small discussion on what is this project about, and we can take to the details. Over to you, Vaishnavi.
Yes, thank you, sir. The link for the same, we will be sending it across in the WhatsApp group and also through the email. So interested participants do join and register it so you can get it notified. Thank you for the today's session. I would like to thank all the speakers for enlightening us with the STEP conferences topics. If for any feedback or any queries, please do give us a feedback on the mail. Thank you.
Thank you all from my end. Thank you all for joining together for a good cause. Thank you.
Yeah, thank you. Good night.
Thank you, one and all.
Thank you, sir. Good night.
Good night, sir.
Thank you, everyone.
Good night, sir.